Basically, Dr. Laidley is going to give us an overview of the current state of the market. And then for about 20 minutes, he's going to talk to us about treatment of neuroendocrine tumors with lutetium dotatate. He'll hand off to Dr. Probst at that point, who will, for about 20 minutes, tell us about treatment of PSMA, treatment of prostate cancer rather with PSMA, and then have some closing comments about the future, and then a little time for questions. Get your phones out and take a scan. We do have some interactive polling questions throughout. We'll start with an introductory one here in a moment, and just as you're getting ready for that, I'll just mention that each of the presenters will have a polling question at the end of their talk, but they will preview that at the beginning of their talk so you can see what the question is and you can be thinking about it as they go through. So if you're ready, we'll do our first question. And did I advance that too quickly? The question said, it's still at the top there, are you currently providing radioligand therapy for either neuroendocrine tumor or metastatic castrate-resistant prostate cancer at your institution? Okay, so that's reasonably stabilized. So a little under half of the audience is not doing either yet, but perhaps hoping to after this. And a few more are doing neuroendocrine than prostate, which I think probably reflects the current state of availability in Canada. So I'll hand off to Dr. Laidley.
Thank you very much. Thank you for the introduction. It's a pleasure to be here today to talk about the recent landscape and available products in the market for radioligand therapy and radioligand imaging. So in terms of the neuroendocrine space, many of you are familiar with, I guess, Lu-Dotatate, which has been approved since, I think it's 3 years ago. Obviously, this is the mainstay product for for radioligand therapy in Canada, with Pluvicto coming up very quickly. Just to make a comment that the PCPA just made a recommendation for the endorsement of pancreatic NETs, so we're very optimistic that we'll see pancreatic neuroendocrine tumors outside of Quebec, because Quebec currently has funding, so we're expecting to see some positive traction for pancreatic neuroendocrine tumors. NetSpot, like all theragnostics, obviously the diagnostic component is very important. We do have NetSpot, which is approved approximately a year after Lu-Dotatate. Many provinces are currently using it. And more recently, NetVision is another gallium-68 product that is available, which was out of UHN. So in terms of NetSpot, as I mentioned, it's broadly funded across Canada. I'm pretty sure most provinces now have NetSpot for the assessment of neuroendocrine tumors. Very few provinces from our discussions before the talk that would not have access. And Lu-Dotatate, again, is very broadly funded for the treatment of midgut tumors, maybe with Quebec the only province that currently funds the Health Canada label of pancreatic and small bowel. But again, optimistic that we'll have both in the coming, hopefully, year or so or less. In terms of radioligand therapy for prostate cancer, and Dr. Probst will go over this in quite detail, Health Canada approval in August of 2022. So we're seeing approval for neuroendocrine and prostate within a few years of each other. So this is only the beginning of our radioligand therapy landscape. I won't go through the label because Dr. Probst will go through that. And in terms of imaging, again, kind of like neuroendocrine, we have the therapeutic approved first, then we have the diagnostic agents. I think we've maybe some lessons learned about approval of therapy and diagnostic agents. So hopefully in the future, we'll start seeing these agents coming out closer together. Currently, we have Illuccix and Locumets, which are gallium-based. And just to make a comment to say that fluorinated compounds such as 1007, we are expecting that this compound may be put forward to Health Canada approval, hopefully in the next 18 to 24 months. So again, the availability of products will be significantly improved over the next couple of years. Some avenues to access lutetium PSMA therapy in Canada. There's a number of clinical trials. I think a critical one is PR21 or Pluto. This is open across Canada. Ontario, we just opened a couple of sites, and that's looking at PSMA 617 versus docetaxel. PSMA 4 is just read out, and you can see some of the details there. In terms of access, we know a lot of provinces in Canada, or all provinces in Canada, have no provincial reimbursement yet. So for many patients that want to access Pluvicto, the current avenues include clinics in Montreal and BC. So I'm just going to go through some slides now regarding treatment of neuroendocrine patients with lutetium dotatate. This is more high level sort of stuff, sort of, I guess, clinical experience, I hope, and maybe some things that I think are important. So not a lot of data to be presented. So this is to reflect on. This is a question we'll have at the end. So just give you a second to take a look. And this will come up again later. So I'm going to kind of focus my talk on patient selection, management, and assessment of patients on PRT, and some post-treatment considerations. So in terms of patient selection, I mean, this is the the NETTER-1 schema. So again, patients that have midgut tumors, this is a pretty obvious one, well-differentiated tumors, G1, G2, who currently progressed on sandostatin. In this case, it was, SSA in terms of lanreotide, sandostatin. Of course, we also sort of would use the progression on lanreotide as a marker for consideration of lutetium dotatate as well. So that's kind of the label for in terms of the NETTER study. But of course, what is a good patient? So really, we're looking at the NETTER-1 population, but we generally think of PRT as being pretty agnostic to the primary site. There are patients that have neuroendocrine tumors in rectal or lung or fields of paragangliomas or even potentially neuroblastomas. I mean, the efficacy may be different across different tumor types. However, when you compare the results to different treatments that may exist or be used for the treatment of these diseases, in general, when you look at many of the retrospective studies that have been done, the outcomes with PRT are generally pretty favorable and toxicity is pretty low. So again, hopefully over time, we will maybe move beyond NETTER-1, we'll move more into pancreatic, and hopefully we'll generate some data looking at the treatment of neuroendocrine tumors and across multiple neuroendocrine tumor sites. So again, general principles of selection of PRT, and this is kind of data that's considered appropriate today, although I'll show a slide at the end that may sort of influence our patient selection. So generally patients with progressive unresectable disease post-SSA. And for many of you, if you don't know, SSAs are somatostatin analogs, so that's lanreotide or sandostatin. Again, patients that perhaps may not have progressive disease on an SSA, but clinically we look at the burden of disease when they're diagnosed. Are they biochemically active? Sometimes we treat these patients with liver-directed therapies, but sometimes we feel based on their clinical status that they may not be appropriate to wait too much longer before we treat their systemic disease. So the second one is more of a clinical practice thing. The first one is generally accepted as generally the primary reason to move forward with PRT. So one of the great things about treating neuroendocrine patients and all of our other theragnostic patients that we have the ability to image patients. So many of you are familiar with the PET-NET score. This is looking at gallium and FDG imaging. For the most part, most patients that are well differentiated are going to have sort of that positive gallium, negative FDG. There are certain examples, and I'll show an example later, that patients would probably be best served by having that dual imaging and looking to assess whether this patient may have maybe targeted therapy to the discordant disease or maybe not giving treatment at all. So we use the PET-NET score as best as we can in Ontario. For many of you who practice here, getting access to both these imaging agents can be challenging. So we do use this, and this kind of helps us guide patient management. And again, this is another example of which patients do you think would be more FDG positive and which ones would be more SSTR positive. Again, the higher the grade, so more G2 and G3. And of course, the current label for treatment in Ontario, at least, does not specify whether it's G2 or well-differentiated G3. So we will generally treat either or. And in the cases of G3, well-differentiated, we will typically always get an FDG PET to make sure that we're not mistreating the patients. So this is just an example of a patient that I saw very recently who had a bronchial met. You can see the tumor in the right lower lobe medially, kind of iffy uptake in the right hilum. And then if you look at the image on the right with the liver, very minimal uptake in the liver. This was actually, the biopsy came from the liver, and that was an atypical lung carcinoid. So in this case, I'd be pretty reluctant to treat this patient with PRRT. So again, I don't have the FDG to show you for this one, but I would expect that that liver lesion would be quite positive and discordant with the gallium dotatate. Again, looking at renal function, this comes up a lot. There's obviously people are very worried about or have been worried about renal dysfunction and how low can you treat patients. You know, we always worry about radiation-induced issues and radiation toxicity for the kidneys. Many of you treat neuroendocrine patients know we give them solutions of arginine lysine to protect the kidneys. Our experience has generally been the most clinical trials cut off at 50. We treat people pretty regularly at GFRs of 30 and really have not seen any significant renal toxicity. And I follow my patients for at least usually 1 to 2 to 3 years, if not longer. So I think for neuroendocrine patients, for the most part, I think treating down to GFRs of 30 is pretty safe and pretty reasonable. And we looked at our registry data where we treated patients generally with GFRs over 50, and over time we followed them for up to 5 years, and we didn't see any significant renal toxicity over time. So just as a caveat, if you have a patient that comes with a GFR of less than 50, it's probably not going to be a contraindication. Important to treat neuroendocrine patients as a team. This is just our team in London. I'm not going to go into all the specific details, but I mean, there's lots of treatments for NETs. There's pretty well every specialty that's listed there has some form of treatment for neuroendocrine tumors. So it's one of the cool sites of, you know, diseases where really the multidisciplinary team all have, you know, for the most part, some treatment options to give. So it's important because sequencing of treatments is complex, and sometimes you get referrals for PRT and they're not really good candidates. So we really need to bring this information back to the tumor board and make decisions on how to treat patients. Just to say that first-line therapy, Novartis's NETTER-2 study just read out, and some early data to suggest that maybe first-line therapy may be appropriate for higher G2 and G3 patients. So unlike the previous NETTER-1 where it's post-SSA progression, now we're looking at first-line therapy. So stay tuned for this. I think there's more data coming out in the coming year. Management of patients, you know, we give patients antiemetics. There's a question about giving dexamethasone in terms of downregulation of somatostatin receptors. I think it's more of a theoretical, I guess. I'm not sure I've seen it in practice. Post-PRT, though, there is some evidence or some low evidence to suggest that there might be a higher risk of obstruction post-PRT with mesenteric disease, peritoneal disease, and we've instituted a policy of giving patients sort of a reasonable course of steroids over the coming weeks after we treat patients to help reduce the risk of bowel obstruction. I guess we'll have to wait and see. Treatment delays, treatment dose reductions, and treatment cancellation, very important to monitor patients. I would say we tend to delay patients more than we dose reduce, and very rarely do we ever have to cancel patients. So we do the following, usually follow patients' blood work for anemia, neutropenia, and thrombocytopenia. Typically, we see mostly thrombocytopenias, and they can be sometimes quite resilient, and sometimes it takes a year or so for people's counts to recover. So it's important to be following these patients with blood work after each cycle, as you know, and then make dose adjustments on the day of if necessary. Very rarely do we have to treat and cancel, but something to consider, and you should always have in the back of your mind, there may be patients that you may want to move in earlier. This is just an example of doing the post-therapy imaging. You can see generally a very favorable response to the liver metastases and some of the bone mets. So we do post-imaging, we think it's important. And why is it important? So this is an example of a patient who had a neuroendocrine tumor it was G3. We treated her 2 cycles. We didn't want to keep continuing to treat her unless we had confirmation that there was at least no progression. Came back and said progression, but when we looked at the post-therapy imaging, we really were expecting this to be very favorable. So this is an example of a patient's imaging on the right. On the left was the pre-treatment imaging, and on the left was the interim PET imaging. And in general, it looks like there was actually a favorable response. So, and sometimes the post-therapy imaging will be very helpful. And in this case, we continued out all 4 cycles in this lady who had a grade 3 tumor and having good response. Post-treatment considerations, I don't have that many more slides. So this is just an example of a patient who completed therapy in 2019, monitored very regularly 4 to 6 months. Basically, imaging came back and says no significant change. This is an example of a patient who pre-PRT PET scan was on the left, and then 3 years later repeated the PET scan. Very easily, I think many of you will identify that this is significantly progressed. So this is something that I sort of call anatomical creep. As you're imaging patients every 3 to 6 months, really depends on your radiologist who's reading the study. Are they going back looking at 6 or 12 or 18 months? Most times, if you tell them go back and look at 3 years ago, they don't do it. So unfortunately, that's what we have to deal with. So just something to keep in mind. Can functional imaging help with response assessment? It's not really been validated that well, although this is an example of a patient with CT on the left and the combined fusion imaging on the right. You can see that the easier lesions to measure, the hypodense lesions, probably not that relevant for the disease, but all the tumors kind of in and around. So if you're, depending on who your radiologist is reading the study, they may very easily measure that lesion that I marked with an arrow. Probably not that helpful. So I think, there's lots of room for improvement in monitoring and assessing response. And long-term side effects is important to monitor for MDS. It is a known entity. It's about 1.8% in NETTER1. And in our experience of about 212 patients, about 1.4%. Retreatment, I think this is my last slide. We do retreat patients. It hasn't been studied very well in a randomized fashion. However, we have NET retreat trial, which is going to be a CCTG trial, and Action 1, which is an alpha emitter retreatment protocol. So details to come. Well, there we go. I guess you guys can answer the question there. I think that's my last slide. Please. Do I need to move forward or? Oh. There we go. Everyone loves PRT. It's great. Maybe not the answer I was looking for, but. All right, just to say, I'll leave it for there, but I was hoping people would maybe pick up on the flavor of a multidisciplinary approach, but when in doubt, if you're medical school answering questions, look for the one that looks more holistic and favorable to everyone. So PRT is great, but I think it has to be done in context with looking at all the other options and looking at the disease state. So 12% would need to be higher, but thanks so much.
So hi, everybody. I'm going to switch gears a little bit and talk about some PSMA theragnostics and prostate cancer stuff. So this is my question to reflect upon. So take a look at this and we'll get you the poll. We'll get the poll going afterwards. So regarding radioligand therapy, PSMA targeted RLT, which of the following is not true? So these are the possibilities. So theragnostic pair, obviously the PSMA theranostic pair is PSMA 617 and PSMA 11. PSMA 11 loaded with gallium 68, and then the therapeutic loaded with lutetium. The conserve pharmacophore, the business end of the molecule that interfaces with the PSMA protein is conserved. Interestingly, you can load gallium onto PSMA 617, and if you send your patients to Sherbrooke, Quebec for imaging, they're actually getting PSMA 617 PET scans. Interesting. When I read a PET scan for theragnostics, there's two things that I'm thinking about, and there's two things that you should be thinking about when you read PET scans for theragnostics. One is the SUV, uptake intensity, how much target is there in that lesion. And the other thing I think about is concordance fraction, is to say does all of the patient's disease harbor the target and with the right intensity. So these are the things when I'm looking at a PET scan, whether it be for NETs or prostate cancer, that I'm thinking about. How did we define positive? Well, Krenning kind of, kicked this off, and this was imported into the prostate cancer space. And he said, well, we'll make the liver the cutoff. So Krenning 3, Krenning 4, basically anything that's hotter than the liver is what you want to be treating. And that this was, the Nutter-1 trial had 90% of patients with Krenning 3 and Krenning 4, and 100% of the Vision trial patients had lesions that were hotter than the liver because that was an entry criteria. So diagnostic positivity is not equal to theragnostic positivity. Diagnostic positivity means I could make a diagnosis, and theragnostic positivity means I could potentially treat a lesion. So here's a patient, FDG and PSMA PET side by side. These are done 1 week from each other. So this is a diagnostically positive supraclavicular node. I can tell you that that's a prostate cancer nodal metastasis. That's a lot of FDG, which also helps me make that diagnosis, but it's not theranostically positive. This, however, is a theranostically positive chest node, and I could possibly potentially get enough beta particles in there to make a difference and treat that node. So this is an important thing to think about when you're reading these PET scans. Polyclonality is the #1 enemy of theragnostics, and I'm going to show you a few examples of polyclonality and why dual PET imaging is probably helpful in picking this up. So this is a PSMA PET scan in a gentleman who was being evaluated for radioligand therapy, obviously has a lot of disease in the skeleton, and the disease in the skeleton is significantly hotter than the liver. So at first glance, you might think, okay, this is a good candidate for radioligand therapy. But looking closely at the CT, well, he has some big adenopathy, and that big adenopathy in the retroperitoneum does not pick up PSMA to any significant degree. So let's get an FDG PET on that just to make sure that that's an active lesion, and sure enough, the FDG is strongly positive. So putting the MIPS side by side, you'll see that they look very, very different. We have two different cancers here, essentially. Now, it's all prostate cancer, but we have two different molecular signatures, different tumor types. We have FDG positive disease, which is PSMA negative, and PSMA positive disease, which is FDG negative. So this patient is not a good candidate for radioligand therapy. The Vision PSMA positivity criteria were based on contrast-enhanced CT. They did include soft tissue lesions that were associated with a bone metastasis, but true osseous metastatic disease is you can only find discordance if you're doing FDG PET. So this is, again, the same patient, PSMA PET, FDG PET, and you see how those scans fit together almost like pieces of a puzzle. Large sacral lesion here with a lot of discordance on FDG PET, which was negative on PSMA PET. And there's no way you could know that there was a discordant lesion and not no disease there, because the CT scan looks very, very abnormal. And the bone scan, I guarantee you, is also very, very abnormal. So FDG PSMA PET is the only way to detect discordant disease in the skeleton. Another patient, this is a good candidate for radioligand therapy. This is a gentleman with almost a negative FDG PET scan, very, very, very positive PSMA PET scan, discrete lesions, no heterogeneity. All those bone lesions look very, very hot. The SUV max, the study-wide SUV max was 112. So those are the numbers that I want to see. So 100% concordance for FDG, very high expression. So this is kind of the perfect candidate. This is like you see this and you go, oh yes, definitely. I want to give this guy Pluvicto. This is a patient, another example of a patient that you would not treat. So this is a gentleman, again, PSMA PET, FDG PET. I'll highlight the lesions here for you. There's not enough PSMA avidity in these lesions. So this was a no-go for PSMA RLT. The PSMA expression is too low to consider radioligand therapy. The two ways of doing the imaging, the two main approaches are dual PET imaging, which is the therapy, and Vision, which is versus contrast CT. If you do cross-trial comparisons, which you're not supposed to do, but I will anyways, you'll notice that the screen fail rate, the imaging-based screen fail rate in therapy is almost 30%. So almost a third of the patients were excluded based on imaging, whereas in Vision it was in the range of 12-13% were excluded based on imaging. But if you look at the results, the therapy results are much more impressive than the Vision trial results. They got 66% PSA 50s versus 46% PSA 50s. So that makes all the sense in the world. You hyper select the patients and you get better results. If you open up your door a little wider, your results are going to be less impressive. So what should you be thinking about and what should you be including in your theranostic reports? This is kind of the framework that I use. Now, this is not evidence-based. This is just kind of my feeling about things, but basically, these are the things that I think about and that I try to include in my reports and in my conversations with clinicians. The study-wide SUV max, what are the numbers that you want to see? Well, I want to see high numbers. I want to see 60, 70, 75 and above. I want to see no discordant disease. FDG PET is the best concordance test. It is a better concordance test than contrast CT. Obviously, if you have no discordant disease, you have 100% concordance fraction and you have no intralesional heterogeneity. These are the numbers that I want to see. And on the other side of the graph, the exclusion. Discordant disease in the liver is a no-go. Study-wide SUV max less than 5, that's a no-go, and so on. So I think, yes, ultimately you have to get to a yes or no. Are you going to treat the patient or are you not going to treat the patient? But splitting it into a binary question of is the patient PSMA positive, I think is the wrong approach. And I encourage nuclear medicine doctors and clinicians, medical oncologists, and whoever's referring to really get into the nitty-gritty, to really get into the details of the imaging and ask the tough questions. What's the study-wide SUV max? Even beyond the liver positivity, we know that higher SUVs is more uptake, and more uptake is better response. What's the concordance fraction? What the concordance test you use? So the tough questions, I think, are going to give us a better indication of how good is the patient for radioligand therapy. Some practical tips in starting radioligand therapy at your hospital if you don't already have it. Lots of people are going to be involved, but I want to highlight the special partnership between medical oncology and nuclear medicine here. If your medical oncologists and your nuclear medicine physicians are not talking early and often, you're going to have difficulty with this program. So get these people talking, get these people's, these people, they should be on speed dial for this program to really work. I think this is the key partnership here. Nuclear medicine can take different roles in the treatment of patients. You can be the imaging and infusion center, which is basically a requisition comes in, a report comes out, and you just infuse the patient. You can take over care of the patient entirely, or you could do kind of in the middle. The JGH model at my hospital is kind of a middle ground. We do know who's on treatment. We do follow them. We do see them at every time they come in for radioligand therapy infusions, but we don't take over care. They continue to see the medical oncologist during treatment. How is the flow happen? This is not the right answer. This just happens to be how we do it at my hospital. The patients are, of course, identified in medical oncology, so they have to be aware of the indications. They have to be aware of the availability. The first thing that happens is the medical oncologist will sign a requisition for PSMA PET, and then the PSMA PET scan will get done. We will come back with a yes or a no. So whenever I see a radioligand therapy request for imaging, the report, the conclusion of the report has to say yes or no, I would treat this patient or I would not treat this patient. If you haven't given the clinician a yes or no, I think you haven't fully done what you should do. Once we send back that report says, yes, we would treat the patient, the medical oncologist will then sign a requisition, say, please give cycle 1. We'll give cycle 1 and we'll send the patient back to medical oncology for follow-up. So they'll continue to follow the patients with CBCs and imaging. Keep your dosing protocol simple. I think this is a super important slide because you can complicate your life with gravity methods and pumps and all sorts of complicated things. But PSMA 617 is not pharmacologically active in the sense that the PSMA inhibition itself doesn't have any immediate effect on the patient. So don't complicate your life with infusion protocols, okay? This is how it works at the Jewish. The patient presents to nuclear medicine at 1. By 1:10, we've given the PO pre-meds. We've started the IV. The dose is pushed over about 1 minute at 1:20 p.m. And at 1:30 p.m., the patient's out, okay? One day, you're gonna have huge volumes here. So keeping it simple is gonna help you a lot. We do the imaging the next day, the next morning. Everybody gets whole body planar imaging. You can do it a couple hours later if you want to, but personally, we like to get the patient out of the department and bring them back the next day. Radiation safety is nothing to worry about. It's you have a 6.7 half-life. We use this Biodex shield for IV push, so they load it into the shield, they just push it. It is urinary excreted, so in my protocol, you'll notice that the patient is out before they pee in the department. So they're not voiding the day of the infusion. They're not voiding in my department, so I don't have to worry about beta particles in my toilet. The The dose rate constant, if you calculate 200 millicuries as point source estimates, 56 microsieverts per hour or 1 meter, which is roughly equivalent to 40 millicuries of technetium. So a one-day protocol MIBI has roughly the same point source estimate in terms of exposure to your technologists and to whoever else is around. So not a big deal. They get this one pager for discharge instructions, very, very simple stuff. Basically, watch out for the urine, watch out for pregnant women and children, and they have an anti-nausea prescription, which we'll sign for them at the bottom in case they need it. So super simple. Patient, it comes in, 30 minutes later, they're out. They come back the next day for imaging with this one page instruction, and it's gone really, really well. Laboratory follow-up is the basic MCRPC stuff, CBC, PSAs, your chemistries. We check the CA and testosterone every so often, make sure they're still, on the ADT. In terms of adverse events, if you do the this is the vision data, so PSMA 617 arm versus best standard of care, and I've done the math for you. And the math, of course, is the difference between the quote-unquote placebo arm and PSMA 617. So these are treatment emergent adverse effects. So this is the difference is attributable to PSMA 617. So the patients will tell you if you ask them, yeah, my mouth is a little dry. I'm not eating those saltine crackers every day. Some fatigue and some GI upset, usually a couple of days after the infusion related to GI uptake of PSMA radioligands. Very well tolerated drug. The patients are not complaining so much. A majority of these AEs, a large majority of these areas are grade 1, 2, so easy to manage and not a big deal. So the cycles, it's every 6-week cycles, 200 millicuries until progressive disease toxicity or 6 cycles given. Those are my personal numbers at the Jewish. I did the math. 60% stop for disease progression, 0 stops for unacceptable toxicity personally. And we've, of course, completed the flip side of that is we've completed 40% of the patients that we've treated. Disease progressions, we look at the patient, obviously pain, ECOG, skeletal events, pictures. So we continue to follow the patients with conventional imaging, CT, chest, abdomen, pelvis, bone scan, and the post-lutetium imaging I think is very important. And of course the PSA. The PSA is very important. This is not radium-223. You can absolutely follow the PSA. The PSA is highly informative in these patients. Chest, abdomen, pelvis, RECIST 1.1, bone scan, PCW, G3, 2+2 rule, beware of flare, and post-lutetium imaging. Some people have suggested that 2 new lesions is progressive disease. Do you need to confirm that with conventional imaging? These are question marks. The PSA after 2 cycles is strongly predictive of response, and I'll show you some data about that. Don't bother restaging with PSMA PET. Okay, I know that's in the guidelines everywhere, but unless you have infinity PSMA PET slots, save them for new patients. You often have PSMA negative failures, which you'll miss on the PET scan. You have post-lutetium images, which are free, quote unquote, because the tracer's already been paid for and administered. You should save your access for new patients and other indications. I don't think anyone in Canada has infinity PSMA PET where they can go and, just dole it out willy-nilly. Get true baselines for all your things. You're going to help yourself. True baselines for CT, chest, abdomen, pelvis, and bone scans. If you start treatment and you're operating on a CT that was done 6 months ago, you don't know where you're starting. So you know where you're starting, get good baselines, and you'll know where you're at. Assessment frequency, we do whole body planar imaging with every cycle. We do PSA 4 to 5 weeks post cycle with clinic visits. And chest, abdomen, pelvis depends on what your PSA is doing. So if your PSA is falling, you could probably wait until after cycle 4. If your PSA is rising, look early, you're going to find progression. This is what I mean by PSA after 2 cycles. It's strongly predictive. So 12 weeks is just before cycle 3. You've given 2 doses. If you have a 90% PSA decline, you're doing really well. Those patients are going to have a phenomenal outcome. They're going to do super well given their highly pretreated MCRPC patients post chemotherapy. If there's no PSA decline or your PSA is rising after 2 cycles, those patients are not doing well. Just to give you an idea, I'm going to overlay the placebo arm. This is the placebo arm as standard of care, had a median OS of 11.3 months. If you got PSMA 617, you were in the active treatment arm, and you had no PSA decline by 12 weeks, you were doing worse than the placebo arm. So no PSA decline or a PSA increase after 2 cycles. Be very careful. Push pause, take a look, because something is not going right. Okay, post-therapy imaging, this is an example of the same patient across all 6 cycles, cycles 1 through 6. You can see on the bottom as the PSA falls, that scan normalizes, and as the patient starts to fail, PSA starts to rise again, that scan becomes abnormal. This is a PSMA positive failure mode. What do I mean by that? Use 2 ways to fail this radioligand therapy. You can fail with PSMA positive disease and you can fail with PSMA negative disease. This is a PSMA positive failure mode. So after cycle 1, the PSA is 500. The liver, let's take a look. After cycle 2, the PSA is 730. That liver looks a whole lot worse, right? Even the other lobe of the liver looks a whole lot worse. So this is a PSMA positive failure mode. That drug is not working. We discontinued the patient. We did get a contrast CT confirmation. You see that after cycle 2, there's a whole bunch of new disease in the liver here, a whole bunch of new metastatic disease. Okay, so we did confirm this with conventional imaging. This is a PSMA negative failure mode. So at PSA, the cycle 1 was 619. And then after cycle 3, that liver looks a lot better, right? You go, okay, well, there's a lot less disease in the liver. Is this a patient that's responding? The PSA was 2,500. So probably the patient's not responding. Again, we got the CT confirming extensive infiltrative metastatic disease to the liver. So the PSA told the correct story. And if you were just looking at this post-therapy imaging, you could be falsely reassured that the patient was responding. This was not a response. This was a PSMA negative failure mode. So in conclusion, my top PSA 617 tips. My top PSA 617 tips. Do a lesion by lesion analysis for PSMA eligibility. It's not enough to spin the MIP. You need to look at every lesion and make sure you have no exclusionary lesions. Get FDG when you have heterogeneity or PSMA PET or a question. Problem-solving scan, get the FDG. Use a short and sweet infusion protocol. Do not complicate your life with long, complicated infusion protocols. Do get the lutetium post-therapy imaging if you can. Don't restage with PSMA PET. Fall back on your conventional imaging and your post-therapy lutetium imaging if you can get it. Use CT and bone scan to restage. Vision did not restage with PSMA PET. And be very careful if your PSA is climbing after 2 cycles. Put it on pause, stop it, restage with conventional imaging. Take a close look if your PSA is climbing after 2 cycles. So the future of radioligand therapy, where do we go from here? I think where we go from here is going to be, it's kind of obvious. We've seen it already. New disease states, right? So we're in last line with MCRPC. We're going to move forward. We have the PSMA-4 data, which was just published or just released 2 days ago. So that's a positive trial. PSMA addition. NETTER2 is, as we heard, moving into first line. New diseases using approved molecules. So Lu-Dotatate is being evaluated for GBM. New isotopes, we've all heard about actinium-225, and then finally new targets, FAPI and GRPR are going to be exciting targets, and there's many others. So this is the audience question. Regarding PSMA radioligand therapy, which of the following is not true? So whole body lutetium can offer valuable response information. Discordant disease in bone can only be seen with dual imaging. Lutetium can be administered IV push over 1 minute. PSA following 2 cycles is strongly indicative of the expected response. And restaging of lutetium PSMA therapy should be with PSMA PET. So which was not correct? So go ahead and answer that. All right, good. So yes, I personally don't believe you should restage with PSMA PET. I think in Canada we don't have enough access that we can do that. There is a PSMA negative failure mode which you will miss. There is post-lutetium imaging, which is almost as good, and the Vision trial did not include restaging with PSMA PET. All the restaging was done with conventional imaging. So I think if you want to be an evidence-based purist, you should stick to conventional imaging restaging.
Great, thanks. Yeah, a lot of information. So this is a little loud. So good to go? Yeah, thanks. So this is actually our last slide moving forward. We thought we'd sort of depart with some common themes for you if you're looking into implementing a theranostic program. So it's different than what we've been talking about, and I was sort of wondering how am I going to transition into this slide, and then it occurred to me that, you know, really what we're talking about here would be a great next symposium at some point in the near future, perhaps. So I'll just read through these. My colleagues have much more experience than me, and we'll have lots of time, I think, in a moment for questions, so we can pursue these as you like. So as Dr. Laidley pointed out, and Dr. Probst as well, multidisciplinary cooperation is really critical. Appropriate and timely PET availability, that is different across the country. Different areas have better access than others, but clearly you cannot do these therapies without good PET availability. Resources, of course, are huge. You need buy-in from your management, and I say at multiple levels. That's, you know, from your nuclear medicine department on up through the hospital and maybe your provincial health authority. This is not sort of a small undertaking that you're doing here. And resources means facilities, right? Treatment rooms, other bits of hardware that you might need, but data management as well. This is a whole new process. And I remember when we started looking into this, and somebody pointed out that, you know, this is more like running an IR, interventional radiology group, or an oncology group than perhaps an imaging department that some of you, many of us work within. Personnel obviously are huge, physicians, and Dr. Laidley has emphasized that we need to enhance our teaching of this in our residency programs. We heard this morning about the technologist shortage in Canada, which we're all familiar with. Depending on how fancy you're getting with your treatments, you may want a physicist, and you need a lot of support staff around that. So just to reiterate that, you know, this is not some very minor addition to your nuclear medicine program. This is a very big undertaking, and to really make the point to decision makers that we really are becoming an important pillar of cancer treatment. So we'll stop there, and I think we have good time for questions. So anybody wants to step up to the mic?
Much. Question is for Dr. Probst. The question is, have you ever looked into the cause of PSMA negative failure? What causes?
What causes the PSMA negative failure mode?
Yeah.
You select for the PSMA negative clones. So there's, you know, microscopic heterogeneity, and you have PSMA negative clones and PSMA positive clones, and you successfully treat the PSMA positive clones, and then the PSMA negative clones blow up. So that's I think the question that I kind of, you know, I'm thinking that there's some, you know, room to run with is the PSMA positive failure modes. Like, what causes the PSMA positive failure modes? That's more, to me, that's more conceptually difficult. Like, we have super high expression of the theranostic target. We're getting a lot of beta particles in there. What causes these cells to continue to survive? And I think the alpha PSMA may, you know, overcome that lutetium. We've seen some data on some post-lutetium PSMA positive failure modes that then respond to alpha therapy. But I think the PSMA negative failure modes are just clonal selection. We select with our drug for disease that's PSMA negative, and that's what you see explode. That's my guess.
And the question is, why does not that happen in all cases?
Why does it not happen in all cases?
Yeah.
Well, lutetium PSMA is not a cure, right? Everybody, you know, there's nobody's on this drug forever. The failures are inevitable. So you can fail with one of two failure modes, but ultimately resistance is a given. 100% of patients become resistant to treatment.
Yes, and there were some slight association with PSMA and the progression of the disease. So in those cases, I was wondering if those patients have been on anti-androgen therapy, or, you know, because anti-androgen can impact the level of PSMA, right?
Yes,
so,
absolutely,
yeah.
absolutely. The PSMA expression is driven by the androgen receptor pathway, and 100% of the patients that I've treated and seen that I've showed you or were on ADT, you know, continuous ADT with castrate levels of testosterone. So yes, and they had, all of them were post ARAT, so they're all had failed either abiraterone, enzalutamide, darolutamide, you know, one of. And so yes, but you're absolutely correct in that it's an androgen receptor driven pathway.
Okay, thank you.
Question for Dr. Laidley. Thank you very much for your presentation, and Dr. Probst. Regarding post-PRT steroids, is that something you give just to specific patients, like you mentioned, mesenteric disease, bowel obstruction? Fine. What about other patients? Is it something that you titrate according to disease? Like, what's your algorithm for that? Because the reason I ask is that every time I ask the question to someone, I always get a different answer. And obviously, I don't think there's a clear guideline on what to do. I just wanted to get your experience on this. Is there certain patients that kind of raise a flag more for you, like large volume liver metastases, or other type of subset of patients where you're going to say, oh no, you need to have steroids? Because some people don't give any steroids, and patients do fine. One patient that I was worried about, I gave him steroids, and he's like, oh, I forgot to take it. I said, well, how'd you do? He's like, I didn't feel anything. So I'm like, perfect. So yeah, I just wanted to get your experience on that, or your experience at your center, not necessarily like your personal experience, but what have you heard, what have you seen regarding the necessity for these steroids post-PRT in different patient subsets?
Great question. I think the easy answer to say is maybe I don't think really anybody knows. I mean, the publications or the suggestions to use steroids after PRT to reduce the rate of bowel obstruction, it's not really based on very high level evidence. It's kind of, I think, out of Jonathan Strasberg's, he published something a few years ago. And I would say in general, I've treated a lot of patients over the last 10 years or so, and very few patients I have seen have bowel obstructions post-PRT. I will say I have seen lots of patients that come to me and they just had a bowel obstruction, or they have bowel obstructions in the past, or they develop bowel obstructions while on therapy. I don't really get a sense per se that they're related. However, I'm becoming a bit more sensitive to that if the possibility that the sort of short course of steroids may in fact help reduce some inflammation and reduce that risk or improve the recovery time, then I'm willing to try, because I don't think there's a lot of risk to using the steroids. So for patients that like I've had a few patients over the last 6 months that have had recent bowel obstructions or bowel obstructions on PRT, I will definitely give them like a 2-week course of dexamethasone, usually around 10 milligrams, and then taper. It's not really based on high, and then if they don't have bowel obstructions, you're like, oh, well, I guess I did something. But if you didn't give them, you don't really know. So I think it maybe has to be looked at in a randomized fashion. But the rate of bowel obstruction on PRT, I think, is pretty low. So it might be hard to get the evidence. So I use it because the risk benefit is pretty low, and I don't really know if it works a lot, but at least I think I'm treating the physician, not the patient sometimes.
Thank you. Regarding the dosimetry of different forms of the PSA preparation, I mean, lutetium prepared radiopharmaceuticals, what kind or what the adopted artificial intelligence programs for dosimetry for the different forms? Knowing that these different forms bioavailability can affect the dosimetry. Thank you.
I mean, dosimetry is a big can of worms. I have to say we don't have a lot of experience with dosimetry at our institution. We were participating in a study where we were doing it as part of the osmosis trial. We currently have the MIM package, which is our software. So we're just now experimenting kind of with dosing of doing dosimetry. We're currently doing sort of 3 to 4 days of imaging. You can do dosimetry down to 1 day according to some of the packages. So we're really, I think there's a lot of uncertainty is how much dosimetry improves outcomes. Does it improve safety? Does it enhance efficacy? I mean, I don't think we have that data. No one has really done a randomized study looking at either one. I mean, I think an easy study would be to do PSMA or lutetium and even just do one day of imaging and do a dosimetry protocol and see if you could look at differences in escalating or de-escalating doses to improve efficacy and reduce toxicity. So I don't know what the answer is, but I'm not sure I answered your question either, though.
Yeah, sorry for that. But regarding the approval of Canada Health is based on safety or
So is the
the
Health
approval,
Canada
yeah,
approval.
for the
Health Canada approval for,
these agents.
oh,
For tape. Pluvicto and Lu-Dotatate.
oh, it's all standard dose. There's no dosimetry.
I mean, relative dosimetry for organs and so on, not the absolute global dosimetry.
Yeah, so the approval is based on the phase 3 trials, and the phase 3 trials, the dosimetry is not at all, if it is included, it's not at all a primary endpoint. So the dosimetry is done in phase 1 and phase 2, and then, you know, you go on in phase 3, and then the phase 3 data is what informs regulatory, you know, decisions. And the regulatory decisions is based on RPFS and OS, period. So nobody cares about dosimetry in phase 3. Fixed dose. Yeah, so everything's fixed dose, right? I can't call up Novartis and say, send me 320 millicuries for my patient. It's 200, that's it, take it or leave it. You can throw some in the garbage if you want to and give less, but they're not gonna give you more. And so it's functionally, it's fixed dose. And until someone shows in an RCT that a personalized approach is better than a fixed dose empiric approach, then it's going to be fixed dose for everybody who's using the commercial product for both.
Just a comment. It's not out of ordinary. We had a trial recently. I'm from Los Angeles. That for phase 3, FDA asked to do a dosimetry for that therapy. So then they came up with the dose. But I agree, it's mostly done in phase 1 and 2.
Right. But we agree that the FDA is not going to ever approve a molecule based on dosimetry. Right.
Yeah, we also don't really know if like 4 cycles or 6 cycles or 8 cycles, like we don't really know how many cycles is the best for each individual patient. We just have to work within the confines of what was studied. But for sure, there's got to be patients where, you know, 3 cycles would be great or 5 cycles would be best, but we can't really tell.
Why 4 cycles? Why 6? I think, you know, it was a bunch of experts got together in the room and said, let's go for 6, you know, realistically. There you go. Yeah, so open questions. Thank you.
Thank you very much for presentation. Just my question is regarding the discordant fraction. How much the new application and new software can be helpful for decision making?
Software?
Yes.
So we do everything.
Because we don't do that, you know, regularly. You know, the new software offer, you know, some fraction, tumor volume, burden, and you know can compare, you know, the FTG versus, you know, PSMA. How much the new software can be helpful?
So that's an excellent question, and I don't know the answer because I'm still using software from like 2009, which is 100% manual, has no AI, has no fancy anything, and I have to just look at the pictures myself and, you know, draw calipers and do math on my iPhone. So I don't know anything about software for this, but it seems like a great opportunity because it seems like something we can either automate or semi-automate with some relative ease, and it makes sense to do that. I don't know if you have.
Yeah, I was going to say, like, I've given talks about this many times, and there is missed opportunities with all our post-therapy imaging. It's not particularly popular to do post-therapy imaging, but I think as nuclear medicine physicians, we like it because it is free and it does give us an idea of change. So I think it's maybe it's something where we in the future we can integrate, you know, tools that could be perhaps centrally monitored or assess looking at tumor volume or like tumor lesion glycolysis or total lesion activity, if you want to call it that, for PSMA. I think there might be an opportunity to see signals of improvement or progression, or look at, tools that look at discordance between PSMA and FDG and some spatially congruent imaging. I think the technology is there. We do have some MIM software. Acceleris, if you have Acceleris, does not have that, as far as I know, at least in the versions I've seen. So there are some advanced tools. I think some of these theranostic trials are not necessarily designed by nuclear medicine physicians, so they're often probably discussed with med-oncs who, design really good trials, but they don't actually know about some of these advanced tools. And I think these could be secondary, tertiary endpoints that could be evaluated with very little effort, I think. So I think opportunities for our research colleagues and our pharma companies who develop these trials. And then, maybe we'll find out that there is some value there. So, yeah, I think there's definitely lots of really interesting tools.
If I comment, I think we looked at some of the data. There are, as you said, good AI software, but you need to do evaluation. So we did a preliminary evaluation of our first cohort with Pluvicto. We did FDG and PSMA. And then we came up with some heterogeneity index. We used the AI to do the total body burden, but it was just in 7 patients. It was some correlation with response to the therapy, but as I said, you need to do more studies. But it's good to have the tool if you have access. There are several vendors providing this, but as more centers gather the data, we can combine the data and look into it.
And ask you each a question about the post-therapy scans. And we all know we're looking out for the small percentage of patients who progress. And we all see the images of the people who respond dramatically. But I think in between, in our experience, there are a lot of people who are just stable. So I wonder if you could just tell us sort of what your experience is, the rough numbers that you actually see improvement versus stability, and what you counsel the patients, because everybody's wondering what their scan is going to show, and they expect much better changes than perhaps we actually see.
Sure, I'll go first. Unfortunately for NETs, the response rates, or objective response rates, are fairly low, at least from the ability to detect on a post-therapy scan. We have some pretty old equipment. We have good software, but we have really old equipment. So finding the differences between 3 or 4 millimeter change is impossible. So I usually just tell people at first visit, don't expect there to be changes. And then you don't feel disappointment when you get your first, second, third post-therapy scan. I will caution, we haven't published it yet, but we've had very good responders for NETs. And the rates of progression within 6 months are very high. And these patients often have gone on to have chemo, and it's been very difficult to treat. So I'm very mindful of the patients that have this sort of rapid, complete response. So we're working on publishing that soon. It's a very small number because objective response rates are low, but I'm very cautious on the super responder. So I used to be excited. Now I secretly just kind of keep a very close eye. So for me, mostly stable, and I tell the patients, so they're pretty happy about that.
Same for PSMA?
So no, there is a difference in PSMA land. So I have the same approaches as you. I tell everybody right away, I say stable disease is a win. So put that in your win column. And then when you tell them your disease is stable, it hasn't progressed, everyone's like, yeah, that's it. So manage expectations. And the pancreatic NETs are going to be a little more likely to show change than the other ones. But in PSMA land, things change. In PSMA land, in MCRPC, things change, and they change much faster than in NET. So it's a dynamic process, and you see things change. Things get better and get worse across 2-3 cycles. And it's relevant, and I do the imaging, and I do think there's a difference between the NET and the MCRPC spaces in terms of post-therapy imaging change, because post-therapy imaging change is rare in NETs, but it's actually quite common in MCRPC.
Great. Well, I think our time is up. So thanks everybody for coming out, and enjoy the break.